Thank you so much. Exceptionally kind introduction. Thank you so much. And thank you, Nihal, and the entire team for inviting me to Vellore to be part of this phenomenal program. Thank you so much. And I'm also glad to follow the previous speaker who presented, this young woman with PCOS and then went on to develop gestational diabetes and in other issues. I also just maybe later when we discuss, like to know how much weight she gained during the pregnancy, which could be very germane to all that happened. But what I'm going to talk about is maternal obesity and what impact that has. We're not talking GDM, we're not talking gestational hypertension or PCOS, just obesity and the impact it has on the pregnancy, the mother and the child, both short term and in the long term. And just want to start by the story of a very young woman I met just last week, 32 years old. She was visiting from Luxembourg, actually, as a 7-year-old child with autism. And she's been trying to get pregnant, has had 2 miscarriages, and she's come to find out, what she should do. And her BMI is 34, and it was 32 when she had the first baby. And why I talk about her is we now know that neurodevelopmental issues in the offspring is linked to maternal obesity. Miscarriages are linked to maternal obesity. So let me, I'll briefly talk about the scope of the problem and consequences of it for the current pregnancy, some mechanisms, metabolic, inflammatory, and genetics, and maternal and offspring health outcomes, and what can we do as far as weight management. And I think we'll come back full circle that everything ultimately has to be done pre-conception. So addressing obesity in women, this is data from the NFHS-5, which is the latest NFHS that we have, National Family Health Survey. And when compared with NFHS-4, you can see that 24% of women are obese. And this is using a BMI of 25, and for that Indian cutoffs, 23 is overweight. So probably an even bigger number of women are overweight. And another important thing about NFHS is this is not women of all ages. Typically they are surveying 15 to 49. So for all practical purposes, NFHS is data of women of reproductive age. And the number of women of reproductive age in India, that alone is 332 million. The number of babies born in India per year is 25 million, more than the population of Sri Lanka and almost the population of Australia. So our problems are big. And in addition to this 24% I showed, if you just look at Tamil Nadu, which is where we are, and you can see comparison between NFHS 4 and 5, 40% of women of reproductive age are over the BMI of 25. And why is this significant? Chronic non-communicable disease burden among reproductive age women in India, evidence from the recent surveys shows that both single morbidity and multi-morbidity are pretty high among these young women. And among these multi-morbidities, and you can see this wide range of multi-morbidities, the nutritional conditions, overweight, obesity, underweight, micronutrient deficiencies, all of them bubble up to the top. So nutritional disorders and conditions are right at the top. And just to bring up another point, obesity is the most common problem of women of reproductive age globally. And why is this happening? And as you can see, nutrition transition, changing lifestyles, changing leisure time activities like watching television, women are less active, but slowly changing socio-cultural norms and beliefs. The food industry, food is plenty everywhere, television and use of mobile phones, mental health. women seem to have more stress, especially those working in the IT industry, less sleep, and of course maternal GDM. And like I said, if 25 million babies are born, and even if we have a conservative estimate of something like 10% of the women have GDM, it's still a huge number. But probably the numbers are closer to 15 to 20%. And then there is this other big issue of gestational weight gain. And gestational weight gain, in India, we are always having this dual paradox. On the one hand, we have people who are underweight, and then we have overweight. We have women who gain less weight. The Garbhini data, which I'll show later, showed that women are not gaining enough weight, a certain percentage of them. But if you look here through the first pregnancy and second pregnancy, the gestational weight gain, and then there is retention of this gestational weight gain, and probably more weight also gained during the postpartum period, leading to metabolic consequences and later in life. And plus our socio-cultural challenges, women's agency, women's freedom to do the kind of things that they want to is still an issue, which is why I said change is coming, but change is not coming fast enough. So if you look at a woman, just for the women, and look at complications for the pregnancy alone, everything from difficulty conceiving to miscarriages, gestational diabetes, gestational hypertension, preeclampsia, preterm birth, emergency C-section, and obesity is not an indication for C-section, induced labor, postpartum hemorrhage, stillbirth, and all of those happening. Then I want to go through some of the data that's been shown in this absolutely fabulous paper by Catalano and others on obesity in pregnancy. And if you look here, pregnancy and delivery complication, in addition to some things I mentioned, there's also depression and labor complications. And fetal outcomes, we never associated congenital malformations with obesity. Always thought of it for GDM, but never with just obesity. Congenital malformation, macrosomia, and large for gestational age. And then the postpartum complications, including difficulties with breastfeeding. And we'll talk about that later. And delayed onset and shortened duration of breastfeeding, postpartum depression, and hemorrhage and infections. But really what we also need to look at is pregnancy is a window to future chronic disease. That's another thing. It's not a one-off thing, and it's a window to future chronic disease. Women who have completely normal pregnancies have less risk of future chronic disease, whereas those women who have any of these have greater risk of future NCDs. And just to show you, this is from the US, and when you look at women, the trends in obesity class, and as the years have gone by, those numbers have changed significantly, and so has it in our country. And this study actually from the US shows you all this that I talked about, from miscarriage to GDM and gestational hypertension are really high up on the list when women are obese. But in addition to that, all the other complications that I have mentioned before. And one more fact that I want to highlight is when someone has, let's say, a miscarriage and also has another complication, or they have preterm delivery and give birth to a small baby, their problems are amplified in the future in terms of presenting 10 years or less than 10 years or more than 10 years later with cardiovascular disease or stroke or other complications. And risk of adverse outcomes associate, I already talked about this. What about in India? And this is a study from Tamil Nadu, maternal obesity and pregnancy outcomes in perspective of the new Asian Indian guidelines. And this is significant because we really need to start looking at overweight as more than 20, BMI of 23, and obesity as something more than 25. And if you look at the moms, again, hypertensive disorders, preeclampsia, GDM, insulin requirements, induction of labor, the entire gamut, also seen in women from India. And this is, I wanted to show the gestational diabetes compared with the non-obese and the obese, very, very significantly higher. And you know that the consequences of GDM in terms of future type 2 diabetes, diabetes in the offspring, obesity in the offspring, and the mom herself having cardiovascular disease and potential, maybe other things. We don't know yet about cancer, but that's also looming large. And then if you look at lean and obese moms, there's a 40% decrease in insulin sensitivity in lean and obese women over time, but in a trend for a great, obese women start with a lower insulin sensitivity, but as they go along, there's a trend towards a greater decrease in obese women. What about the same study from South India in terms of the babies? You can see from miscarriage, and I'm really, intrigued by this congenital malformation and multiple other complications that are happening to the baby. We were always thinking in terms of large babies and macrosomia, but look at the neural tube defects and cleft palate and even cardiovascular abnormalities. All of these are common in babies born to mothers who are overweight. And at what level of overweight do these things happen? And if you see here, whether it's fetal death or stillbirth, it can happen even at a maternal BMI of 25. So I think it's really important for us to start talking to our women in the reproductive age, the young women, to maintain their BMI at an even lower level or at a healthy normal level. So what's going on that's causing all of these problems? One of them is, of course, the placenta and the intrauterine environment. And you can see here from inflammatory markers to lipotoxicity to oxidative stress and overactivation of the placental macrophages. Fetal epigenetics, differential expression of microRNA, and then in the breast milk. So it's not just the mother who's obese having difficulty with latching or other issues when they're breastfeeding, but actually the breast milk having increased IL-6 and decreased neuroprotective factors, and of course fetal microbiome. Cesarean sections, alter fetal microbiome. Now, one of the other areas that's evolving in a very big way is neurodevelopmental issues. And you can see from neuropsychiatric issues like anxiety and depression to other issues like attention deficit disorders, autism spectrum disorders, cognitive dysfunction in children. Now, moving on to what is happening in terms of fetal programming, the developmental origins of health and disease. We again typically associated this with low birth weight babies and nutrition, that is, babies who are deprived of nutrition. What's happening to fetuses of obese mothers? They develop insulin resistance in utero as well. This again is a fantastic paper that I would recommend everybody to read. And then if you see here in the markers that are high compared between the lean mothers and the obese mothers, and both in the maternal I can understand, but look at the umbilical cord levels that are high. And if you look at the umbilical cord insulin and the umbilical cord glucose and compare it with the lean and the obese women, so this is happening in utero as well. So is the fetus developing insulin resistance because of excess fat mass? We cannot, and they go ahead to say we cannot answer this question directly. We've shown that increased fetal adiposity and fetal insulin resistance are closely associated. And maternal obesity has a strong positive correlation with fetal insulin resistance as well, even after adjustment. And this one is fetal HOMA-IR and the maternal HOMA-IR. Fetal HOMA-IR is better than the maternal HOMA-IR because of better insulin sensitivity in utero, but you can see compared to mothers who are obese, the fetal HOMA-IR is abnormal in babies who are born to obese mothers. So where does all this start? The placenta seems to be a nutrient sensor. It integrates maternal and fetal nutritional cues, and through regulation of nutrient sensing pathways, attempts to match the fetal demand and the fetal supply. So many changes that are happening at the placental level, and as you can see in obesity, there are vascular defects, there are, villi issues, there are, so many other changes that are happening at the placenta level. And they've also shown that, that over a period of time, be it pre-pregnancy, early pregnancy, or late pregnancy, longitudinal changes over time of fat mass that's happening in lean and obese women, and these changes are significant over time and also between groups. So this is again a very important finding. I said I'll come back to this, neurodevelopmental and other issues. Multiple factors are at play, and one of the important things that I want to highlight is also again the infant dysbiosis, which may be happening partly because of the breastfeeding, partly because of the cesarean section, and just the maternal microbiome being different can impact on the fetal microbiome. So, we've seen why this may be happening, and we've also seen what is happening, but what are the solutions that are there? Awareness regarding consequences of maternal weight on mother, child, and the pregnancy. Adherence to gestational weight gain recommendations. Maybe next year, if there is a meeting, we're just going to start a big nationwide study on this, on maternal weight gain during pregnancy, pre-pregnancy weight, and advice given to them on weight gain and what are the things that are influencing. Adherence to gestational weight gain, preconception care, attention to metabolic health of women of reproductive age. We've been focusing on anemia, which is very, very important. We've been focusing on vaccination, which is very, very important. And we've been focusing a little bit on, some other aspects of nutrient deficiencies, but completely, I think we have, dropped the ball on the weight of the woman who's planning a pregnancy. And a life course approach to women's health, activism and advocacy in this area, and a collaborative and cohesive approach. So the IOM guidelines, which is all that we have, and of course there are many groups that are working on, do we need to change some things for India or Asia? Do we need to change something for gestational diabetes or women who are, of course they give recommendation for obese women, but do we have to fine tune these recommendations? They've been around since 2009, I think, but how many women adhere to this? And then what about weight loss strategies, be it with lifestyle modification, be it with pharmacotherapy, and be it with bariatric surgery? We know that anything that is initiated after the pregnancy, many things, usually has no real impact. The horse is out of the barn, as they say. But when you look at surgical weight loss through bariatric surgery, what they have found is all those complications I listed, almost all of them significantly come down. On the downside, the babies may be smaller and the mother may have a lot of some nutritional deficiencies, and that has to be taken into account very seriously. And like I said, we need to balance, because we are working with women who are underweight and overweight, so need to take into account what is the mother's preconception BMI and what is her social status, and what kind of MNT are we going to prescribe. One size absolutely does not fit all in our country. Again, coming back to this fabulous paper by Catalano, and so they give us this roadmap. What should we do before conception, during pregnancy, 1 to 10 months before delivery, during labor delivery, and after delivery? This is for women who are overweight and obese. Of course, we definitely have to discuss subfertility and other obesity associated risks, recommend lifestyle weight loss interventions, and very carefully, and I think in a sensitive manner, women have to be told about all these potential complications. And I don't think women are going to take it lightly if they are aware that these things can happen to them just on the basis of obesity. And postpartum is really preconception for the next pregnancy. So that between pregnancy is again a time when we absolutely are not paying attention. Most of the GDM women show up in the next pregnancy with frank diabetes. Most of the women show up with more weight gain. So that is like I say, a low-hanging fruit that we can address. We've been myopic about this whole thing for a long time. Women cannot suddenly one morning wake up and become a healthy mom. So we need to start things at, from an adolescent age and go on. That is the only way. A healthy girl will become a healthy woman, will become a healthy mom. And we also know that none of these interventions that are started after the pregnancy usually, have great impact. And the Lancet, this paper has clearly shown us things like weight, we'll have to start well ahead of time, not the 3 months and 6 months, but I'll take 6 months if I can get it, and at least talk about a 5%, 10% weight loss, which is, again, can make major metabolic changes. So towards that end, this is my last slide. Along with Professor Jane Hurst from Oxford, we are launching the 3B project, which is before, between, and beyond pregnancy. Most of these are educational programs, empowerment programs. So this Yuvadi means a young woman in Tamil and in Hindi, which is raising awareness of young women about health issues and to change their lifestyle before pregnancy. Thank you.
Thank you, Chairpersons, and thank you, CMC, for calling me back again after 10 years of finishing my education here. I finished my thesis in one of the topic was gestational diabetes and genetics, so I'll be talking in brief about this in the next few minutes. So we'll have introduction followed by, is gestational diabetes and type 2 diabetes, are they two sides of the same coin? What are the advances in the genetics and beta cell dysfunction in pregnancy that we have come across? Briefly about Modi genetics and gestational diabetes, and then finally to see whether gestational diabetes and type 2 diabetes are they two separate coins which actually look similar. So gestational diabetes, we all know, is associated with varying degree of carbohydrate intolerance, and the current recent global prevalence is found to be exaggerated to around 21 million, where 80% is gestational diabetes, and the other forms of diabetes that are detected during pregnancy or prior to pregnancy form around 18 to 20%. And we have also seen that data shows that Asian women are almost 11 times more likely to develop gestational diabetes than other countries. Therefore, some of the genetic studies are more from this group, that is the Asian women. So are they two sides of the same coin? One of the reasons why we are likely to call them two sides of the same coin is because they have risk factors that are very similar with respect to the family history, age, hypertension, polycystic ovarian disease, and obesity. Like we just saw, obesity and its association with multiple problems. Further, we also know that 50% of women after delivery do develop type 2 diabetes within 10 years of the diagnosis. And there are inflammatory molecules that are increased at a higher level from the adipose tissue of these women. Further, even from the placenta, we see higher expression of these inflammatory molecules, TNF alpha, interleukin 1, interleukin 6 to be there. So diabetes today, we all know, is not just beta cell dysfunction, insulin resistance, but also inflammation plays an important role, because inflammation can not only affect the cause the insulin resistance, but also affect the pancreatic beta cell function also. Further, we also use the term as a format restive, that is type 2 diabetes represented by gestational diabetes due to the glycemic physiology changes during the end of pregnancy, that is in the late second and third trimester, where insulin resistance increases approximately by 50%, mainly predominantly related to the increase in the hormones that are the estrogen, progesterone, leptin, cortisol, and placental lactogen and placental growth hormone. But studies have shown that in pregnancies with GDM, the insulin stimulation rate by glucose uptake into the cells is reduced by almost 54% compared to normal pregnancies, which gives rise to the question of, is there beta cell dysfunction in these gestational diabetes women? Are they similar to type 2 diabetes, or are they different from them? So these beta cell dysfunction in gestational diabetes has been seen to be associated with various stages of insulin signaling cascade, including the pro-insulin synthesis, post-translation modification, gene alteration associated with the insulin signaling. And also this hampers the translocation of GLUT4, which is the primary translocator of glucose molecule in the plasma cell membrane of the cells. So we all know that there is a complex interaction between the environment, genetics and epigenetics, which includes the DNA methylation, histone modification, and the microRNA. And these genes that can affect the diabetes and pregnancy can be related to the inflammatory genes, the defense system genes, and also the immunity genes, along with the other genes that we know that are specifically linked to the development of the beta cell itself. Many of the genome-wide association data have shown that some genetic risk loci for the gestational diabetes impair the insulin secretory response that are actually distinct from type 2 diabetes. So this is what we all know, that genetics plus epigenetic modification and lifestyle with environmental triggers can affect the pregnancy maternal glucose metabolism. If it is only that, then we can relax and think that at the end of pregnancy we get a good pregnancy outcome, it's okay. But we know that this is not going to affect the pregnancy itself, but it's also going to have an impact on the fetal epigenetic alteration, which can unfortunately change the life of the entire fetus and its adult life because of something that it was not responsible at all. So the child can have a good lifestyle, but because of the epigenetic changes during the intrapartum period, it will have an impact on the child, which is very unfortunate. Therefore, we need to spend more time in trying to see how we can best deliver the outcomes to the mother and the baby at the same time, from not just a point of insulin resistance, but also beta cell function. So around 560 genetic loci have been associated with type 2 diabetes, which includes inflammation, insulin resistance, beta cell dysfunction, and also the impact on many other areas which we know diabetes can result from. But it has also seen that only 4 variants, that is near the TCF7L2, CDKAL1, TCF2 and FTO, are predominantly which are having a higher risk of type 2 diabetes, are also seen in gestational diabetes, which means that the typical type 2 diabetes genetic loci are not seen extensively in the gestational diabetes patients. We have seen recently that the CDKA1, the CDKN2A, B and the HHEX were associated with decreased insulin secretion during the 2-hour OGTT used to diagnose gestational diabetes. So if you look at this graph, you can see here there is an overlap of these set of genetic markers which are both highly expressed in gestational diabetes and type 2 diabetes, but the rest of them which are associated with type 2 diabetes are not very well seen with respect to the gestational diabetes. One of the unique thing which is very unique to gestational diabetes is this MTNR1B, which is hardly seen in type 2 diabetes. So I will come to these few of these in the next few slides. So if you look at transcription factor 7 like 2, that is TCF7L2, it encodes the HMG box containing transcription factor and has a role in the WNT signaling pathway and glucose metabolism. So we have seen many variants both in Caucasian and Asian population which are associated with gestational diabetes. Fortunately or unfortunately, there is a very high indicator of TCF7L2, but the genetic variants are extremely variable. Even in the study that we did at Vellore 10 years ago, these variants were entirely different from what we saw in the various other populations. So each population, the gene may be same, but the variants keep changing. So we need a robust method in which the cost factor should be considered in order to get the exact genetic variant that may be pathogenic for that population. In various other populations, we have seen that the KCNQ1 gene, which is associated with membrane repolarization of the beta cell membrane, leading to calcium influx and insulin secretion. If it is affected, it also causes beta cell dysfunction. The MNTR1, which is exclusively seen with respect to gestational diabetes, is expressed in beta cells. It promotes endogenous glucose production and insulin secretion. Inadequate availability of the intracellular CAMP, the insulin signaling pathway, is hampered, leading to beta cell dysfunction. And this data is from the Korean, and there is a large Finland data just published last year which shows that this variant is having a higher sensitivity in terms of its effect size on gestational diabetes. Also in studies from Caucasians and Iraq, it has seen that the insulin receptor substrate 1 is also associated with decreased insulin response in patients with gestational diabetes. The glucokinase, we all know, is associated with higher fasting glucose, is also seen to be associated with lower fetal growth if the genetics is transmitted to the fetus, resulting due to the defect in the glucose sensing and insulin release by the pancreas due to these GCK mutations. There are also IGF-2, BP2, which are associated with the role in embryonic development, cell differentiation, metabolic pathway, and insulin homeostasis. The CDK5 regulatory subunit associated protein is associated with impaired insulin secretion via the P35 CDK3 complexes, and this triggers glucotoxicity in the beta cells and damage the beta cells externally. Finally, the recent one is the BACE2, that is a beta site amyloid polypeptide cleaving enzyme 2, which is a beta cell enriched protease that regulates the pancreatic beta cell function and plays an important role in the insulin receptor trafficking in the pancreatic SS cells. These are not very similar to the typical type 2 diabetes patients that we see. Now coming to MODY, we all know that diabetes is predominantly defined by insulin deficiency and the combination of insulin deficiency and insulin resistance, where type 2 diabetes is polygenic and MODY is the monogenic diabetes with an autosomal dominance inheritance with a high phenotypic penetrance and age of onset usually less than 25 to 35 years. And there is an overlap in terms of its clinical manifestations in the patients that we see during our OPD practice. So this often sometimes leads to misdiagnosis, and then treatment is either insulin or medications are given. We usually figure it out late, but in the early stage we usually tend to misdiagnose them as soon as we see the patient, unless we have a strong, robust family history of MODY type of diabetes. Studies have shown that this may account for up to 5% of all the GDM cases, and most of it is linked to HNF 1A, 1 alpha, 1 beta, 4 alpha, and GCK considered to be important. So there are many other rarer mutations which are also considered to be seen in various populations of gestational diabetes and even young onset diabetes. So we thought we will see in our population. So this was a study done at CMC Vellore in 2013 and 14, where 50 clinically diagnosed MODY subjects with onset of diabetes less than 35 years were subjected to the NGS next generation sequencing using the iron torrent methodology for a panel of 13 MODY genes. In this group, there were 16 pre-gestational diabetes women, 16 overt gestational diabetes, and 18 gestational diabetes, which was defined by the consensus definition in 2010. So all the subjects were screened for all the 13 MODY genes, and MODY variants were seen with probable clinical significance in 9 of these 50 subjects. So among these 9, interestingly, we did not see the HNF1, 4 alpha and the others as most common, but we actually see PDX1, NeuroD3 and CL insulin gene as the others that were seen in this group. So we were not seeing the predominantly reported from the Caucasian population. So 20% of which NeuroD1 and PDX1 were the most common mutations instead of the others that were reported in various other literatures across the world. So we also looked at these genes and tried to screen their parents and the offsprings. After delivery, we called them back and asked for that. We saw that parents of 6 of the 10 pregnant women and 7 of their 17 babies were screened. One had IUGR2 stillborn and 1 with congenital heart disease were not screened. Among them, 6 parents were positive for the same mutation, and 4 in the father and 2 in the mother, and 5 had diabetes, 1 had impaired glucose tolerance among the parents. 3 out of the 7 babies were positive, 2 girls and 1 boy with GCK1, HNF1 alpha and NeuroD1. So this is a tedious process which takes a long time to do. So I think the next generation sequencing is really helping us in order to improve the process, fasten the process and get more data faster to help our patients. Further, we have seen that epigenetic changes in terms of DNA methylation affects the serum interleukin 10 concentrations at the end of pregnancy in GDM1 and GDM, and histone modifications alter the expression of the insulin homeostasis gene which we had just described, among which you can see the MTNR1B is also prominently reflected here. Further, there are differences in the placental mRNA, which are microRNA, which are usually 19 to 24 nucleotides, which are very important and crucial in the post-transcriptional regulation and translation process. And this expression are likely to contribute to the physiological changes that can impact the gestational diabetes and which are unique to gestational diabetes only because of the placenta itself. Among them, the microRNA 518 decreases the expression of PPAR gamma, resulting in insulin resistance. And it was also seen that there are various other microRNAs that have found higher expression exclusively only in women with gestational diabetes as compared to normal pregnancies. So we have seen the genetic changes. We see MODY as a subgroup which may account for around 5% of the population, and there are epigenetic changes that can not only affect the insulin resistance but also affect the beta cell function in these women with diabetes during pregnancy. There are other specific genes that are contributing towards insulin resistance. These are also seen in type 2 diabetes. So there is a common pathway between type 2 diabetes and gestational diabetes that we see in some of these patients. So our gestational diabetes and type 2 diabetes are the two sides of the same coin. These two coins, 10 and 20 rupees coin, you can see are almost looking very, very similar, and the back side is also very similar, but they are two separate coins. They are not the same coins. So they are similar looking, but definitely two separate coins and two separate. So why are they common? Because there are epigenetics, lifestyle factors that contribute towards diabetes and gestational diabetes, with addition of placenta development and its hormones contributing to the insulin resistance. We see as a common pathway for the development of diabetes in these patients. But we have seen that in the genome-wide association studies that have looked at type 2 diabetes and gestational diabetes, only 3 of the JIVA studies have identified only 5 loci, limiting the power to assess to what extent these variants or biological pathways are specific to gestational diabetes. The recently published largest JIVA's data is from Finland, which has looked at 12,000 cases with 131,000 pairs female controls in this FinGen study. This data was looked at from the inpatient hospitalization, outpatient specialty clinics and the birth registry, and they identified around 13 gestational diabetes associated loci, of which 9 were exclusively new. And they also saw that these genetic features are distinct from type 2 diabetes and were identified both at the locus and the genomic scale. You can see here they did an interesting analysis. They looked at type 2 diabetes in men and gestational diabetes, and you can see here there is an overlap to some extent in the beginning, but when you look at towards the end, the type 2 diabetes males, the genes are entirely different from the gestational diabetes genes. So they concluded that the genetics of GDM falls into 2 distinct characteristics. One is the conventional type 2 diabetes, which are looking similar to the general population, including both men and women. Then there is a predominantly influencing mechanism that disrupted during only the pregnancy that can affect the signal transduction and the hormone processing, and they can affect the islet cell, glucose homeostasis, steroidogenesis and the placental expression. So if we pool all these data together, we may be able to develop a polygenic risk score which will help us to predict gestational diabetes, and not only that, further postpartum type 2 diabetes and probably the effect on the fetus also in future. So this is just to show you that the color blue is for the exclusively newly detected genetic loci, and the orange is the old that is previously seen. And again you can see this MTNR1B is considered to be of much significance compared to many other loci. Further, this was very, very interesting that the cell type specificity analysis of the gestational diabetes and type 2 diabetes highlights totally different cell associations. The brain and the pancreas both show clear enrichment of signal in the cell type specificity analysis of the GDM. Results in the brain show that specific association with the hypothalamic and arcuate nucleus neurons in GDM that are actually not seen with type 2 diabetes. So the manifestation of gestational diabetes is not just restricted to the changes or the impact which is looking at the beta cell, but also there are areas beyond the beta cell which can have an impact on the pancreas and its function itself, including the brain. So in conclusion, we all know insulin resistance is very, very important, but beta cell dysfunction and inflammation coupled with the environmental, genetic and epigenetics all play a crucial role in the occurrence of gestational diabetes. So from the data recently published and many other studies, we can clearly say that genetics of gestational diabetes falls into two distinct characteristics, like they are two similar looking coins which are entirely different from each other, and also there is some similarity, which have the conventional type 2 diabetes polygenic risk, and the other being the predominantly influencing the mechanisms that are disrupted in pregnancy. Some of these changes are genetic, some are epigenetic, which includes the differential expression of the microRNAs and the promoter methylation changes that regulate the insulin homeostasis genes. Hope that, like what we saw 10 years back in our own center, that technical improvements may lead to the development of a quick, low-cost genetic test that not only detect the polygenic risk scores in women with gestational diabetes prior to conception or during early gestation, but also have an impact on the future of the mother and the baby together. Thank you.
To keep the ball rolling, Mahesh, so you identified different categories, genetic in GDM and a type 2. Was there any different pattern of OGTT you could focus on?
Those who have gestational diabetes in this group with genetic risk factors have a predominantly higher fasting glucose. So higher fasting glucose should be sort of considered as one of the clues towards thinking that they may have a genetic predisposition as compared to just one our postprandial value.
Yeah, I have another question for you, Dr. Mahesh. Very nice talk, both of you. Very interesting. In my mind, I think it's a very important topic to trying to disentangle the origin of GDM versus type 2 diabetes, because basically they have the same risk factors like affluence, obesity, and many of the same genes, and even the fetal environment actually also. I just wonder about, you did show some discordance of the genetic patterns, and some of the type 2 diabetes genes seems not to pan out as GDM genes, and that there was even one that actually went quite a lot in the negative direction. I think it was ADC 5. So I just wonder if you can speculate about why do you think that can happen? Some genes that increases risk of type 2 diabetes later in life, why do they not cause GDM, or could it be a result of lack of power in the statistical analysis?
Yes, one of the initial reasons that were expressed is that it actually takes a very long period of time. It takes 10-20 years for the changes to be expressed for resulting in type 2 diabetes, and it's a slow process, whereas GDM is a very short period of time. Within 9 months everything happens and it disappears. So because of the short duration, that is one of the reasons. The second thing that they say is that this inflammation, that pattern that is there, may actually be protective for type 2 diabetes in that phase. Therefore, they don't result in expression because of the epigenetic changes. So that is an potential hypothesis as to the epigenetic changes may be protective for type 2 diabetes, but after some time it goes away, and therefore there is unmasking of the type 2 diabetes later on.
At the outset, I would like to thank Dr. Nihal and his team for this academically stimulating atmosphere over here. I will start with this thing about the metformin used in pregnancy. Way back in late 90s when I was resident, there was a discussion on the GDM in one of these conferences. So out of curiosity, being a young resident, I just asked a question, why GDM is like type 2 diabetes? Why not use metformin? Believe me, I was rebuked in the hall. I was made to feel small that metformin in pregnancy, how can you think of using metformin in the pregnancy? And today we know that we are using metformin in pregnancy for the good maternal outcomes, good neonatal outcomes, but possibly long-term metabolic vascular health that requires to be looked into. So in my talk, I will just go through the various aspects. Now, all of you agree with me that diabetes in pregnancy, as has been discussed, it can be pre-gestational diabetes, which can be type 1, type 2, or it can be GDM. And rates of GDM are estimated to be increasing. We know that in India, Dr. Mahesh earlier told that in Southeast Asian countries, 11% increase of GDM is there. And GDM is on increase, and it increases the complications also. So pathophysiology, as I told, is akin to like type 2 diabetes mellitus, and blood glucose control is linked with the outcomes in diabetic pregnancy. Higher the HbA1c, higher are the pregnancy-related problems. So good glycemic control during the first trimester is vital. Hyperglycemia at conception is associated with the risk of congenital malformation. So a point which I'm trying to make is that glycemic control is required in the pregnancy, irrespective whether it's type 1 or type 2 diabetes mellitus. GDM, which occurs in the later part of the pregnancy because of the insulin resistance, are more insulin resistant than obese women. And what are the guidelines for the metformin use in pregnancy? Now, various guidelines, if we see, ADA recommends insulin as a first line and suggests metformin as a secondary option. As per the ADA, if somebody is on the metformin like PCOS, it can be given till the first trimester. After the first trimester, it should be stopped. That was in response to somebody's question, but as ma'am said that you continue to use metformin. So what are we looking at that I'll discuss? As far as the Canadian Diabetic Association is concerned, insulin remains the gold standard while metformin is considered as an alternative. However, there are two guidelines. UK's NICE guidelines and Fetal Medicine, Society of Fetal Medicine, which suggests that metformin should be continued in the pregnancy. So, as far as the mechanism of action of the metformin is concerned, we know it acts at the level of the mitochondria. Ultimately, it decreases ATP and AMPK kinase increase. Now, this AMPK kinase has got multiple effects. It has got insulin sensitizing effect. Besides that, if you look at this cartoon, it is acting at so many organs. So, we have to look at the metformin once we are using in the pregnancy. What are the maternal outcomes? What are the neonatal outcomes? What are the fetal outcomes? And what happens on the long term if we are using metformin to the children when they grow up? As far as glycemic control is concerned, as I told you initially, if there is a poor glycemic control, there are the problems. So numerous studies report that metformin is equivalent or even superior to insulin in glycemic control during pregnancy. This is recently this emerged trial which showed us, which is a placebo controlled trial, metformin early initiation, effectiveness and safety and GDM. It did not show any, as compared to the insulin, there was no difference. There's another study which is going on, MATH-GDM trial, which will evaluate GDM pathogenic mechanism to establish a more individualized treatment approaches. So if somebody is on metformin, how many patients would require additional insulin to control glycemia? In this MIG trials, which was studied in GDM, around 46% of the patients, they required insulin for the glycemic control. Another RCT, they showed that around 20% of the patients, they did require insulin for the glycemic control. And in the sub-analysis, it was found that obesity was correlated with the increased risk of metformin failure. As far as the other outcomes are concerned, available data consistently indicate reduced weight gain with the metformin used during pregnancy, whether we are using it for type 2 diabetes mellitus, GDM, or PCOS, there is a reduced gestational weight gain. The difference in weight gain ranges from 0.47 to 1.8 kg. And what about the effect of metformin on postpartum weight change are still inconclusive. Pregnancy-related hypertensive disorders. Several studies support a trend of reduced risk of gestational hypertensive disorders with metformin use. In MITI trial, which was in type 2 diabetes in pregnancy, the addition of either metformin and placebo to insulin treatment in women with type 2, no difference was observed in collective incidence of gestational hypertension, worsening of the hypertension, preeclampsia. So conflicting signals are there. However, the evidence is inconsistent. About the cesarean delivery, 3 meta-analyses, including GDM, concluded that the risk of cesarean delivery was comparable regardless of the treatment modalities. Recently, a meta-analysis was done. Metformin administration was associated with fewer cesarean deliveries. In MITI trial, also cesarean section was less likely in the pregnant women who were given the metformin vis-a-vis insulin. This is a fantastic cartoon to show that visceral fat mass at the entry at 28 weeks at term. The ladies who are giving metformin at the full term and the postnatal, their visceral fat mass was lower as compared to insulin. And in this cartoon, again, to show if we use metformin vis-a-vis insulin, what happens to the various aspects in terms of the gestational weight gain, glycemic control, pregnancy-related hypertensive disorders, and cesarean delivery. Metformin is either comparable with the insulin or has a better profile when we compare it with the insulin. So as far as maternal outcomes are concerned, metformin has a favorable outcome. Now, risk is passage of metformin from mother to offspring. Around 50 to 100% of the metformin crosses the placenta and goes to the fetus. Metformin is a substrate. We know that many cellular transport systems, including organic, cationic transporter proteins, expressed in placental tissue and are the main effectors in transplacental passage. However, OCT3 expression is low during first trimester and increases progressively with the gestational age. That is why metformin use in early pregnancy is not related with the congenital anomalies. This is a mixed study, the metformin in GDM, which was studied 750 women with GDM at 20 to 23 weeks, given some of them given metformin, other insulin. So primary outcomes of the composite neonatal hyperglycemia, respiratory distress, need for phototherapy, birth trauma, 5 minutes Apgar score less than 7 or prematurity. So what were the outcomes? Rate of primary outcome was similar in two groups. Metformin therapy in GDM is not associated with increased perinatal mortality, but severe hypoglycemia was less common with metformin group. Preterm births are common in metformin group. So that becomes an area of concern. Secondary outcomes, no significant differences between the groups in neonatal anthropometric measures or measurements of umbilical cord serum insulin concentrations. No significant differences between the groups in rate of maternal hypertensive disorders. Greater weight loss in metformin group. Now what happens to gestational age and preterm birth? Numerous studies support that metformin administration in GDM treatment results in earlier gestational age compared to control group. In MIG trials, although the results were statistically significant, but however, they were not clinically significant. 3 meta-analyses show a mean difference of around 0.14, 0.16, and 0.23 weeks in the gestational age. Register-based cohort study examined the effects of metformin administration in GDM, type 2 diabetes, and PCOS. Infants of mothers who received combination treatment with metformin and insulin were more likely to be preterm compared to infants exposed exclusively to insulin. What about the congenital anomalies? As I told you initially, OCT3 expression is less in placenta. So transplacental passage of metformin raises concern about its effect on the fetal growth later on, especially when taken during fetal organogenesis. Studies consistently show that metformin does not increase the overall incidence of major congenital anomalies. But however, there was one study where 50,000 ladies were studied and they found that pulmonary valve atresia were more, but that was found to be incidental finding. Low risk of congenital anomaly malformations in women with pre-existing type 2 diabetes treated with metformin compared with those treated with insulin. What about the birth weight? SGA, LGA, and macrosomia. Metformin exposed neonates weighed less, macrosomia incidence was significantly lower, but no difference was observed in SGA and large for gestational infant race. In MITI study, what they found statistically significant reduction in birth weight, elevation rate of SGA and reduction in the rate of macrosomia in the offspring. The incidence of LGA was similar in both groups. So in various studies, they found that small for gestational age with the metformin use increases. Birth weight was not affected by metformin treatment in the offsprings of the women with PCOS. What about the neonatal hypoglycemia? Various studies support that metformin for treatment of GDM reduces the risk of neonatal hypoglycemia in the offspring. Other neonatal complications, collective verdict that multiple RCTs and meta-analysis is that metformin administration during pregnancy is not associated with NICU admissions, respiratory distress, or reduced Apgar score at 5 minutes. So this is a cartoon to show again the various parameters like gestational age, premature birth, the congenital anomalies, birth weight, macrosomia, LGAs, SGA, neonatal hypoglycemia, Apgar score, NICU, and respiratory distress syndrome. When we compared metformin with insulin, again metformin has either neutral effect or favorable effect, except for the weight SGA. That is, and this weight difference was found to be around 122 grams in one of the studies. Now, are there metabolic programming effect on the fetus? Unlike human embryos, fetus and placenta do have two mitochondria. So, overall effect of metformin administration in pregnancy has yet to be determined. Metformin can affect fetal growth, nutrient bioavailability, and epigenetic programming. Metformin shifts cellular metabolism from anabolic to catabolic state and suppresses growth and transplacental transmission of nutrients, amino acid glucose, despite nutrient-rich environment. The resulting caloric depletion could explain the observed trend for reduced neonatal birth weight and SGA incidence following metformin use in pregnancy. Now, this catabolic state initiated by metformin and nutrient restriction can sustain a developmental environment that predisposes to cardiometabolic diseases in adulthood, like safety hypothesis. Bioavailability of methyl donors, such as folic acid, vitamin B12, as well as a direct effect on 1-carbon metabolism. These changes result in DNA hypomethylation and differential epigenetic signaling. Thus, metformin activity during fetal growth can permanently alter the metabolic programming of the body as per this study. Now, if we see the MIG, that is the follow-up study, what they found Adelaide group and Auckland group. In summary, did metformin protect the children in Auckland mothers by more lean body mass? In that study, what they found at 2 years, Auckland group had more subcutaneous tissue, but around the abdominal waist and total body fat was same. But at the end of 9 years, what they found that they continue to have a higher weight, mid-arm circumference, waist to high ratio and upper arm fat mass. If that be so, then these children are obviously going to have later metabolic or vascular health problems. Intrauterine metformin exposure and offspring to cardiometabolic risk factors, a 5 to 10 year follow-up study of PregMet. This was a study which was done in the PCOS ladies who were giving metformin. So in this 5-year follow-ups, the cardiometabolic risk factors in these children were examined. So what they found, children in metformin group had a higher BMI Z-score than those in the placebo group. These were the ladies of PCOS who were given metformin. Increased BMI in metformin exposed children might indicate potential risk for inferior cardiometabolic health. Implications for adult health cannot be excluded. These are again the long-term follow-up studies, but I'll skip this slide. So all these studies raise the question, metformin appears to be same mechanism as nutrient restriction to promote longevity and inhibit cancer growth, and dietary restriction can program increased cardiovascular risk in the offsprings. Effect of metformin in addition to antenatal diet and lifestyle intervention on fetal growth. This is a gross randomized study. Gross study was done in the obese ladies who were given metformin. So what they found that among overweight pregnant women, addition of metformin did not appreciably impact fetal size or adiposity. Metformin used in obese individual has not protected these ladies from developing GDM or hypertensive disorders. Neonatal, infant and childhood growth restriction following metformin versus insulin treatment. This was a meta-analysis which was published in 2009. So in this study, they again found that low birth weight and postnatal catch-up growth have been reported to be associated with adverse long-term cardiometabolic health issues. Then this was the MITI study which was done, I told you, type 2 diabetes. At 2 years, their anthropometric measures were measured. In the study, favorable effects were seen that children born to the mothers who were given metformin vis-a-vis insulin, same body measures were there in this MITI trial. And recently, this is a long-term impact on the offspring, 5 to 11 years of metformin meta-analysis. This has been published recently by Dr. Deep Datta and his colleagues. What they found, the BMI and waist circumference to height ratio were similar between offsprings born to mothers who received metformin and insulin during pregnancy. At 9 years after childbirth, the total body fat mass and percentage were similar between these offsprings. Visceral adipose tissue volume and liver fat percentage were also similar. The occurrence of obesity and diabetes in the offsprings and the mothers were comparable. In fact, they did other biochemical parameters also like adiponectin, leptin, and ferritin. They found same in this study. And another study to show what happens to the neurodevelopmental disorders. This was a long-term study, systemic review and meta-analysis. Again, they found that even at the 14 years, there were no neurodevelopmental delays. So as of now, there are the conflicting signals coming as far as the metabolic vascular health. Some of the studies RCT show that there is no effect, but some of the studies do show that there is an effect. So final answer is not there as of as far as the long-term metabolic vascular health is concerned. So what should be the clinical approach? Oral agents are preferred in some situations. Metformin can be used after discussing, it's very important, after discussing the known risks and need for long-term safety data and offspring. Now, ADA 224, recently, in fact, 25, they said due to potential growth restriction or acidosis in the setting of placental insufficiency, metformin should not be used in pregnant people with hypertension and preeclampsia or those at risk of intrauterine growth restriction. So in obese pregnant women, even if there is small evidence, metformin could have a role in very obese, BMI more than 35 kg per square meter to minimize weight gain and with no effect on the infant size at birth. However, I repeat, personalized decisions with the risks and benefit have to be discussed. In pregnant women with PCOS, consider using metformin, especially in those with BMI more than 30 kg per square meter. Even if this group of women, metformin also does not reduce the infant size. In GDM, consider metformin very obese who are likely to need insulin, as metformin will reduce the dose needed with the gestational weight gain. As we have seen in the first case which was discussed, insulin requirement kept on increasing. Later on it was 1.5 units per day. In pregnant women with type 2 diabetes already on metformin, consider continuing metformin throughout pregnancy. However, stop taking metformin if there is evidence of fetus being SGA. Consider initiating treatment in obese women who are insulin naive, and consider adding it to those on large doses of insulin to reduce the size. So how to initiate metformin? This was again studied by Dr. Gagan Priya and Dr. Kalra. A typical dosing regimen is to start metformin extended release in the doses of 500 milligram orally, once daily with dinner. If tolerated, increase it to 500 milligram, and gradually we can go to 1 gram BD. So in the nutshell, metformin as an alternative to medicine during pregnancy can be used under different settings, but it has to be discussed with the patient, only then one should take a call. Altered fetal programming and predisposition to childhood obesity and metabolic syndrome during adulthood impede metformin's universal use during pregnancy. Though there are some of the guidelines, like I told you, NICE guidelines and some of the fetal medicine guidelines which say that it should be used. But still, long-term safety as far as the metabolic and vascular health is final answer is we do not have. As critical questions require final verdict, ongoing research on the field must be conducted. Use of metformin requires women to be able to take an informed choice over the balance between its known benefits or any unknown future harm. Thank you, ladies and gentlemen, for patient hearing.
Thank you, Professor Azad Khan, for the kind introduction, and a big thank you to Nihal and Felix and the entire team for having me over here. Today I'm not going to talk on Phetuin A, which is my favorite heptokine, but a different adipokine called Chemerin and its role in the prediction of polycystic ovary syndrome. So PCOS affects 1 in 10 women of childbearing age. Prevalence of PCOS in India is around 10% by the Rotterdam's criteria. Women with metabolic syndrome have a high prevalence of PCOS, and 20 to 30% of PCOS patients develop type 2 diabetes, and that too at a very young age, in their 20s and 30s. So this prevalence is actually double of what is seen in the general adult population in India. Now, most PCOS patients become dysglycemic over time, but if you do fasting plasma glucose and HbA1c at presentation, these two modalities have very poor sensitivity in detecting dysglycemia in PCOS. So if you wish to categorize them as to their risk of IGT or type 2 diabetes, you need to subject all of them to oral glucose tolerance test, which is a huge challenge in apparently healthy PCOS subjects. So this brings us to the question, can we have biomarker or biomarkers to identify women at risk of PCOS? And if you are able to do that, then can we extend this hypothesis further to see if Chemerin, the adipokine I'm going to walk you through about, cutoffs to identify PCOS with dysglycemia also. Since obesity strongly binds PCOS and type 2 diabetes, so we thought this potential biomarker, could it be an adipokine? Now, if you look at the association between Chemerin as an adipokine and metabolic syndrome, so Chemerin regulates inflammation, adipogenesis, and glucose metabolism. High Chemerin levels correlate with obesity, insulin resistance, and systemic inflammation. Chemerin promotes immune cell infiltration in the adipose tissue. So, and now Chemerin is being considered as a potential biomarker for metabolic syndrome and PCOS. So there are multiple studies showing the mechanistic link between metabolic syndrome and Chemerin, and Chemerin receptor knockout has been shown to reduce adiposity and glucose intolerance. Then Chemerin and adiponectin are known to contribute reciprocally to metabolic syndrome, and insulin and metformin are known to regulate circulating and adipose tissue Chemerin levels. So that's about the association between metabolic syndrome and Chemerin. Now moving on to how Chemerin induces metaflammation by causing adipose recruitment and activation of plasmacytoid dendritic cells. So in this diabetes paper where I was a co-author, it was shown that inflamed adipose tissue releases a lot of Chemerin, which then binds to Chemerin receptor present on the surface of plasmacytoid dendritic cells. The inflamed adipose tissue at the same time releases extracellular nucleic acids, which upon binding to their binding proteins, they go on to attach to RAGE, which is a receptor for RAGE on the PDC, and that leads to activation of toll-like receptor 9 or TLR9, which you know has a nuclear location. This leads to production of type 1 interferon, which causes macrophage polarization from anti-inflammatory M2 to pro-inflammatory M1, and then you have those M1 releasing a lot of pro-inflammatory cytokines like TNF alpha, IL-1 beta, and so on to cause insulin resistance. Now, people have reported the association, strong association between Chemerin levels and PCOS. So women with PCOS exhibit significantly higher levels of not only serum Chemerin but also follicular fluid Chemerin levels. Then higher ovarian Chemerin mRNA expression was reported compared to non-PCOS women. Elevated serum Chemerin levels persist regardless of BMI, although levels are higher in obese PCOS women. There is a conflict here because the next paper documents higher serum Chemerin levels to have a strong positive correlation with BMI, fasting insulin, and HOMA-IR. So with this background, we went on to look at the predictive value of Chemerin in diagnosing PCOS. So we recruited 113 treatment-naive PCOS subjects between the age of 18 and 40, and as comparators we had 64 age-matched controls and 40 type 2 diabetes treatment-naive without PCOS. So we then stratified the PCOS population into normal glucose tolerance, impaired glucose tolerance, and type 2 diabetes based on the results of oral glucose tolerance test. Now it's interesting to see that 30 out of 113 patients, they had type 2 diabetes. They did not know that they had type 2 diabetes. These were young adults with, apparently asymptomatic young adults, and when we subjected them to oral glucose tolerance, and they were surprised. We were also surprised to see nearly 1/3 of them having a diagnosis of type 2 diabetes. Busy slide, but if you focus your attention on the top 3 panels, the BMI, body fat, and waist circumference, you will see that there is not much of a difference between the controls and the PCOS with normal glucose tolerance. But when you move to the right, you see that PCOS with type 2 diabetes, that subpopulation had a higher BMI, a much higher total body fat, and a greater waist circumference. But of the 3 parameters, total body fat percentage, more than 30%, had the highest predictive value for type 2 diabetes in PCOS. And if you look at the Chemerin levels here at the bottom, as a group, PCOS subjects had a higher Chemerin level compared to age-matched controls. But when you look at the change in Chemerin levels, when you move across from NGT to IGT2 type 2 diabetes, you see there is a progressive increase with a sky-high Chemerin level in persons of PCOS with type 2 diabetes. And this was associated with a change in pro-inflammatory markers also, the TNF-alpha and the IL-1 beta, most evident in the PCOS with type 2 diabetes and IGT. So on ROC curve analysis, we found that as far as detecting type 2 diabetes in this population is concerned, Chemerin cutoff of 301 nanograms per ml had the optimum trade-off between sensitivity and specificity. And with that cutoff, Chemerin had 85% sensitivity and 89% specificity to detect type 2 diabetes. Using another lower cutoff for IGT of 222, again we found 82% sensitivity and 79% specificity. So serum Chemerin levels correctly identified 79% of the PCOS subjects with type 2 diabetes and 59% of PCOS with impaired glucose tolerance. Chemerin had a very high, you see 89% negative predictive value. So it becomes an useful test in the clinic setting where apparently asymptomatic PCOS subjects come in, you draw a blood sample, do a Chemerin, and if the value is below the cutoff of 309, you can be reasonably certain that they are unlikely to have dysglycemia, type 2 diabetes, so to say. So you can leave them alone. And those who have a value which is above 309, 85% is the positive predictive value to rule in type 2 diabetes. Of course, you need the gold standard test in that subpopulation to confirm the diagnosis, which is your 2-hour OGTT, but it appears to be a very useful test due to its high negative predictive value. Now, since high Chemerin levels are so strongly associated with type 2 diabetes, so we wanted to see if Chemerin correlates with pancreatic beta cell dysfunction. And here we compared the HOMA-IR levels with Chemerin and the HOMA2 beta. And as you can see in this study, we did not find significant correlation between HOMA-IR and Chemerin. On the other hand, there is a significant inverse correlation between Chemerin levels and HOMA2 beta, underpinning the association between high Chemerin levels and pancreatic beta cell dysfunction. So, like I said before, on the right panel you can see Chemerin levels predict PCOS with high degree of accuracy, and the best correlation as far as anthropometric parameters are concerned is with the total body fat. So it shows the strongest correlation with Chemerin. Then in the PCOS with IGT subgroup, again, if you divide them into BMI less than 23, more than 23, waist circumference less than 85 centimeter, more than 85 centimeter, and body fat percentage less than 30, more than 30, you see that the maximum increase in Chemerin level is seen in those having a body fat percentage more than 30. So very strong correlation there. And same is the story in the PCOS subpopulation with type 2 diabetes. Again, the best correlation is seen with Chemerin and total body fat percentage. Now, high Chemerin level also creates a pro-inflammatory state, as you can see over here. Look at the TNF-alpha and look at the type 2 diabetes. And here the TNF-alpha compares to that with, PCOS with type 2 diabetes. It's comparable to that with type 2 diabetes without PCOS. And you can see here the interleukin-1 beta is increased, which is pro-inflammatory, and interleukin-1 receptor antagonist, which is anti-inflammatory. There is a progressive decline as the Chemerin level goes up. So looking at the association between Chemerin with inflammatory markers, here is the inverse relationship between adiponectin and Chemerin, and look at the NF-kappa B level. Again, you can see there is a significant correlation. Since people have reported increased follicular fluid Chemerin levels in PCOS, and as we all know, AMH levels are also increased in the follicular fluid in PCOS. So we just wanted to check the if there's any correlation in the serum levels of AMH and Chemerin, and although there was a trend for AMH correlating with Chemerin, the values did not really reach statistical significance. So here is the paper where we showed that serum Chemerin levels correlated with the severity of dysglycemia in young adult women with polycystic ovary syndrome. Chiranjit Bose, my research fellow, he did the bulk of the work. Then you have Chinmoy, who was my postdoc, is now a faculty at the Department of Biology, Howard Hughes Medical Institute, Chapel Hill, United States. So that's the group. And to conclude, previous studies reported elevated Chemerin levels in follicular fluid as well as in the serum as a potential contributor to increased Chemerin levels in PCOS. We found higher Chemerin levels in PCOS subjects compared to controls, but the dysglycemic PCOS subjects had disproportionately higher Chemerin levels, and the maximum levels were reached in PCOS with new onset type 2 diabetes as detected on the basis of 2-hour oral glucose tolerance test. So serum Chemerin levels showed a negative correlation with HOMA2 beta, suggesting its potential role in pancreatic beta cell dysfunction. So finally, we suggest that Chemerin can be a good screening test because of its high negative predictive value to rule out the evidence of PCOS in apparently healthy population if you screen them at the school level or college level, and then off the PCOS using the different cutoffs that we arrived at based on the ROC curve for IGT, for type 2 diabetes. We can also assess the risk as to having dysglycemia and frank type 2 diabetes, then select the population who are at maximum risk of having type 2 diabetes and subject only that population to the confirmatory gold standard oral glucose tolerance test. I think I'll stop here and thank you for listening.
So because the correlation is well seen with dysglycemia, so is it a factor to do with dysglycemia or a PCOS? And the second one, what happens in lean PCOS?
Yes, so lean PCOS actually we did not look at separately, but as you see the total body fat percentage. The total body fat percentage of more than 30% was discriminatory in terms of the Chemerin levels. And responding to your first question, as a group, PCOS subjects had a higher mean Chemerin level compared to age-matched controls. But within the PCOS group, those having the higher Chemerin levels had a higher risk of dysglycemia. Does that answer your question?
No.
No. Sorry.
Sir, I think because it's just like where the fat mass is going, Chemerin levels are going.
Yes,
it's
yes.
just reflecting the fat mass. That same thing happened with 2 decades back with leptin. So we have a unique entity known as plain PCOS in India. So that's a major crunch we are seeing, though obese and overweight is coming. So this lean PCOS would have been thrown a much more light on the thing.
True, and people have reported high follicular fluid level Chemerin levels, but unfortunately we did not look into that. Thank you.